Hello. Thank you for that wonderful introduction, and thank you for having me here to speak with you today. I've heard such wonderful things about DASON and all that you've accomplished, and it's a real honor to get the opportunity to discuss antibiotic stewardship with you and speak about some of the work that we're doing in the state of Michigan through the Michigan Hospital Medicine Safety Consortium. And for those of you joining from HMS, welcome and thanks for attending. Now, I know that DASON does some great work on the side of inpatient antibiotic stewardship. So today I want to focus on one of my passions and a blind spot we've discovered in antibiotic stewardship, antibiotic overuse at discharge. To illustrate some of the challenges and potential strengths of focusing on discharge, let's start with a story. It's a story that as a hospitalist I know all too well, and that each of you probably also knows all too well, the story and the day of the life of the hospitalist. And I'm picking on hospitalists today, mainly because I am one. But let's just say it's been a long, rough Friday, and you've spent all day rounding, discharging, only to admit again nearly back to your cap. But your shift is nearly almost over, and though you know it's bad luck to check your watch, you sneak a peek. Only 5 minutes to go. But alas, no such luck. You have an admission from the emergency room, a patient with altered mental status. So you shrug it off and head down to the ER, where you first meet your patient. She's an 80-year-old woman with dementia. Unfortunately, she presents alone from her nursing home. The chief complaint listed on her paperwork is altered mental status. However, she's unable to provide any history and her records are incomplete. You cannot find any mention of a baseline mental status. After an unsuccessful attempt to engage the patient in conversation, you attempt to perform a physical exam. She has stable vital signs, all within normal limits, but is oriented only to her name. She babbles continuously, making a lung exam impossible and does not follow commands, but she has no obvious findings to explain her mental status. However, again, her exam is severely limited. Laboratory findings are mostly within normal limits, although she has a mildly elevated white blood cell count and neutrophil count. Of course, before you've even seen the patient, a host of other tests have also been ordered, including a urinalysis, which is positive for leukocyte esterase, also with numerous white blood cells and occasional bacteria, unfortunately also filled with squamous cells, meaning it likely wasn't a clean catch. The patient has also had a chest x-ray, but unfortunately, just like she couldn't cooperate with your exam, she couldn't cooperate with the technician, so the x-ray is largely useless due to poor positioning and effort, and the radiologist reports that she can't rule out an underlying infection. The patient also had a head CT, which, although you weren't expecting it, rules out an acute bleed. Does make note that truly an MRI would be more sensitive for acute ischemia. So I don't know about you, but I have patients that I see like this all the time. So I'd like you to take a moment to think about what you would do. What's your next step? Would you A, provide supportive care and get a chest CT to evaluate for pneumonia? Would you B, provide supportive care and then empirically treat with vancomycin and DASON, given that she's coming from a nursing home? Would you C, provide supportive care and empirically treat with ceftriaxone? Perhaps you're thinking that she has a urinary tract infection. Would you D, provide supportive care, fluids and medication review, and ask the night team to check the patient in an hour or two to see how she's responded? Or would you give up? Medicine was never supposed to be this hard. Well, I'll tell you what the physician does in this case. Big question mark, confused, doesn't really know what's going on or what to do, talks with her colleagues and says, well, I don't know either, but what I do know is that she can't go back to her nursing home. So at this point, think maybe I'll just give her antibiotics and hopefully she'll get better. And this reminds me of Leo Tolstoy in War and Peace, who says, though the doctors treated him, let his blood, and gave him medications to drink, he nevertheless recovered. Sometimes we do things in medicine that aren't actually helpful, and in this case, antibiotics may be one. Now let's talk about the same case and change a couple things. You have the same 80-year-old woman presenting with dementia from her nursing home, but this time around, her blood pressure is 72/40 and her heart rate is 110. But then you also find scribbled in the ambulance notes that she was started on Ambien for the first time last night. So here you have a potential alternative cause for her altered mental status, but the patient's also unstable. So what do you do here? Same choices, same options. The problem is these are both hard situations, and neither of them has a clear clinical solution. I'll let you know first what's guideline recommended. These guidelines are straight off the press just last month. The Infectious Disease Society of America released updated guidelines regarding management of asymptomatic bacteria and specifically really addressed both of these cases. For example, they say in older patients with functional and or cognitive impairment with bacteria and delirium or acute mental status changes, and without local genitourinary symptoms or other systemic signs of infection, for example, fever or hemodynamic instability, we recommend assessment for other causes and careful observation rather than antimicrobial treatment. So this means for our first patient, no antibiotics, but rather continue to work her up, provide supportive management, maybe gather additional information, and observe, see how she responds. But for patient number 2, a little bit less clear cut. In fact, the guidelines say for the bacteriuric patient with fever and other signs of potentially consistent with a severe infection like sepsis, and without a localizing source, broad spectrum antimicrobial therapy should be directed against urinary and non-urinary sources. So it's hard to know for our patient because does she really have sepsis or is she hypotensive from a medication? And this is the problem. This is why it's often really hard to decide how you should initially treat these patients. When a patient first comes into the hospital, we rarely know exactly what is going on. Instead, we're working on incomplete data, incomplete history and records, pending test results, etc. At this point, our diagnostic certainty is low. But this is also the time when the risk of bad outcomes is usually highest. If you don't treat an infection early, or for example, diagnose a heart attack in time, mortality can increase. So diagnostic certainty is low and risk is high. But what happens after a few days, specifically as a patient approaches being stable for discharge? Well, in our case, what happened is that the patient's vital signs stabilized with fluids and broad-spectrum antibiotics. Her procalcitonin comes back and is negative. Her mental status clears, and she denies any current or past urinary or pulmonary symptoms. In fact, she says to you directly, "Hey doc, I never want to take that Ambien medicine again. It made me feel awful the second I took it." So maybe it's not correct to think we can look back in time and predict exactly which patients will do well immediately. There are those who it's definitely safe to wait on, but there are those in whom risk and diagnostic uncertainty often force potentially unnecessary antibiotic use. But if we can't intervene immediately, perhaps we can intervene later, after the hospital course has gone on, when now the patient's risk is less because vital signs have stabled and you know more about them, and now you have higher diagnostic certainty. Test results have come back, you've gathered additional history, and overall you've just been able to watch her and see how her clinical course goes. So this is why I'm really focused in on how we treat patients at discharge. I think it's a time when often diagnostic certainty is higher, and maybe we can stop some of the empiric antibiotics that have been prescribed. And the risk is also lower. You've deemed the patient safe enough to go home, so hopefully that means that they've been doing better. So after that case, I want to talk a little bit about the overview of our presentation today. I'm going to start briefly by talking about the types of antibiotic overuse at discharge and a way of thinking about overuse. I'm going to talk specifically about why transitions in care are challenging, talk about some of the best practices and potential solutions for antibiotic overuse at discharge, and then talk about a project that we're doing here at the University of Michigan called Road Home, or Reducing Overuse of Antibiotics at Discharge Home. Hopefully, you guys can borrow some of those suggestions to take back to your hospitals as well. So let's first start with talking about the types of antibiotic overuse at discharge. And to do this, I'd like to introduce first the Michigan Hospital Medicine Safety Consortium. So like was mentioned, I'm the hospitalist lead for the antimicrobial use for the consortium. But the consortium has multiple things. We're a collaborative quality initiative of 48 hospitals across the state of Michigan. We're funded by Michigan's Blue Cross and Blue Shield, so they actually pay money to help to provide time for abstractors to collect data on patients. And they have the goal of trying to improve the care of hospitalized patients. Our program director is Dr. Scott Flanders, who leads the multiple initiatives going on through HMS. The key strength of our collaborative is that it's truly multidisciplinary. For example, with the Antimicrobial Use Initiative, we have infectious disease docs. Actually, Dr. Tejal Gandhi, who heads antibiotic stewardship here at the University of Michigan, leads the Antimicrobial Use Initiative, and provides a lot of ID expertise. But then we also have ID docs from across the state who come and represent their hospitals and provide key input. But we also have hospitalists and other frontline providers who provide their suggestions and take back and implement some of these projects. We also have quality leads, either people like chief quality officers, or often it's many of our data abstractors who go back and actually enact these changes and talk to their providers about how to improve. And then we also have pharmacists, whether those be ID pharmacists or clinical pharmacists, who are interested in improving antibiotic use. And together, everybody offers their own strengths to work together to improve antibiotic use in patient care. The Antimicrobial Use Initiative has been going on since late 2016, and we've collected data on 2 cohorts of non-ICU medical patients, those with pneumonia or those who have a discharge diagnosis of pneumonia and received antibiotics during hospitalization, and then patients with a positive urine culture. And to date, we have data on more than 20,000 patients. Now, you may be asking yourself, why these 2 groups of patients? Well, if you look at the infectious diagnoses that trigger inpatient antibiotic use, pneumonia accounts for about 30% of inpatient antibiotic use, and urinary tract infection for another 15%. So if you just hit these top 2 diagnoses, you get about half of the inpatient antibiotic use. Next, you may be asking, why is a hospital medicine or a hospitalist collaborative focused on antibiotic stewardship? Well, who prescribes antibiotics for a patient with pneumonia or urinary tract infection? We looked at this across our state, and we found that the attending physician who prescribed antibiotics was most often a hospitalist. Just over half of our patients received antibiotics based on a hospitalist. A general internist, about a third, and then the rest were family medicine or medicine subspecialists. And again, if you looked at these patients, only 14% had an infectious disease consult at any point during their hospitalization. And this makes sense because IDs really only consulted for the most complex of patients. And many of these patients don't really have that complex of disease. They just have community-acquired pneumonia or a regular kind of run-of-the-mill urinary tract infection. And so these antibiotics are being prescribed by a hospitalist or general internist instead of by infectious diseases physicians. And so we thought really getting hospitalists engaged in improving antibiotic use would be helpful in improving care. The other strength, of course, of our collaborative is just how much data we're able to get. We have abstractors who sit at the hospitals and collect information on patient symptoms, diagnostic testing, antibiotic treatment, and outcomes. We also call patients at 30 days after discharge to collect additional outcomes. And what this really has allowed us to do that's been difficult for a lot of programs is to assess appropriateness. And this includes discharge antibiotic appropriateness. So that's what I'm going to talk to you guys about today. And to do that, I'd like to talk about a broad framework for how we think about antibiotic overuse at discharge. So I think first and foremost are unnecessary antibiotics. So these are antibiotics that are given for a non-infectious or non-bacterial syndrome. And when you think about our first patient, this is probably what she had, is unnecessary antibiotics that were treating delirium that was not caused by an infection, but was instead caused by a medication side effect. So when we looked at patients across our collaborative, we found that about 1 in 8 patients treated for pneumonia with antibiotics actually lacked any symptoms, any pulmonary symptoms, or they had completely normal chest radiographs. We did a small dual physician, so this was 1 hospitalist plus 1 ID physician, who reviewed cases of 90 of these misdiagnosed patients. And the interesting thing we found was that the primary providers for these patients had actually made an alternative diagnosis by discharge in most of the patients. The problem is that diagnoses were added but rarely subtracted. So for example, in your patient with pneumonia, by discharge, they had decided that they actually had a COPD exacerbation or a heart failure exacerbation. But rather than stop antibiotics, they added treatment. So by the end of hospitalization, they were being treated for COPD, CHF, and pneumonia. And because of this, we found that 85% of patients received more than 3 days of antibiotics. These weren't brief empiric treatment courses, but rather prolonged duration, and they were often treated the same as if they'd had an obvious pneumonia with a radiographic infiltrate. I think we also know that unnecessary antibiotics are a big problem when it comes to positive urine cultures. And just as a brief aside, there's a big problem with asymptomatic bacteria. So these are patients who have bacteria in the urine, and that can be with or without pyuria, but they don't have any symptoms. And as the recent guidelines state, these patients really shouldn't be treated with antibiotics, except for a few exceptions. But often these patients receive antibiotics anyway. And we found that 60% of patients with asymptomatic bacteria were still on antibiotics at discharge. And about a third of those were receiving fluoroquinolone antibiotics, which are even more dangerous and put them at high risk of side effects and other adverse events. So we've talked briefly about unnecessary antibiotics, whether that be patients who are misdiagnosed with pneumonia or those who are misdiagnosed with a urinary tract infection. What about patients who actually do have an infection and need antibiotics? Well, there can still be overuse for them. And one of the big places that comes from is excessive antibiotic therapy. So these are patients in whom antibiotic therapy is needed, but antibiotics are prescribed for longer than necessary. Let's start by first looking at patients with community-acquired pneumonia. The recommended antibiotic duration for a patient with community-acquired pneumonia who becomes afebrile and has been clinically stable for about 48 hours is really 5 days of therapy. And this is true both based on guidelines, the older guidelines for community-acquired pneumonia, but it's also been validated in multiple randomized controlled trials and in systematic reviews. So we looked at our patients across the collaborative who had a diagnosis of CAP. We ended up with 6,481 patients with CAP at 48 hospitals. We found that 87% of those were eligible for 5 days. So the other 13% either had a complex pathogen like Pseudomonas or MRSA, or they didn't become clinically stable, or they continued to have fevers. But the vast majority of patients are eligible for that short course 5-day treatment duration. However, we found that despite this, only a quarter of patients eligible for 5 days actually received 5 days. And we could track almost all of excess antibiotic use to one spot. In fact, 93% of excess days occurred after discharge. And this really makes sense if you think about the length of stay for these patients. For most patients with a community-acquired pneumonia, length of stay is somewhere between 3 and 6 days. So if they only need 5 days of antibiotics, often patients don't need to be discharged on any antibiotics at all. So we've talked a little bit about excess duration. What's the final category here? I want to focus for a second on avoidable fluoroquinolones. These are patients in whom an antibiotic is needed, but they're prescribed a fluoroquinolone antibiotic when a safer alternative exists. Now, why focus on fluoroquinolones? Well, the problem with fluoroquinolones is they're associated with a high rate of adverse events. In fact, about 27% of inpatients will suffer an adverse event. That can be something mild, like GI upset or an allergic reaction, but can be something severe, like C. difficile. And in fact, fluoroquinolones are a large driver of C. difficile infection. Even short courses of fluoroquinolone antibiotics can double a patient's risk of C. difficile infection. It's also a risk factor for developing recurrent C. difficile, and decreases in fluoroquinolone prescribing rates have been shown to reduce hospital onset C. difficile rates. Fluoroquinolone prescribing is also associated with antimicrobial resistance, for example, with methicillin-resistant Staphylococcus aureus and with VRE, and also multi-drug resistant gram-negative infections. And an interesting study just out of Lancet earlier this year, the neighborhood rates of fluoroquinolone consumption directly affect patients' rates of having resistant E. coli in their urine, meaning even if you're not receiving a fluoroquinolone, the amount that your neighbors receive directly impacts your risk of having resistant E. coli in your urine. So a lot of reasons here to really try to reduce the amount of fluoroquinolones prescribed if there are equally safe alternatives available. But what we found is that 12% of patients with pneumonia or a urinary tract infection were switched to a fluoroquinolone at discharge, even though they were improving on alternative therapy during hospitalization. There are potentially some avoidable fluoroquinolone days as well that happen at discharge. And the nice thing about this is you can really think about this as a hierarchy. If at all possible, it's most important to stop unnecessary antibiotics. But then the next target should be excessive antibiotics, because these patients need antibiotics, but you shouldn't be prescribing them for as long as you are. And then maybe thinking about avoidable fluoroquinolones as third in the hierarchy. If you can reduce an entire day, that's probably better than reducing an antibiotic class. And so this is how we thought about it. And we measured antibiotic overuse at discharge for all of our patients in our collaborative, so about 28,000 patients to date, a slight majority of whom have pneumonia, and the rest have positive urine culture. What we found is that 74% of patients with pneumonia had antibiotic overuse at discharge, and that 55% of patients with a positive urine culture had antibiotic overuse at discharge. So this is a huge amount. And for each group, if a patient had overuse at discharge, it was about 3.3 days. So if you can really intervene in these patients at discharge, for each patient, you can reduce about 3 days of antibiotic overuse. So I've talked about this a lot and really quantified kind of the magnitude of overuse at discharge. What are the harms with overprescribing? Well, what we do know is that excess antibiotics at discharge increase a patient's risk of developing an antibiotic-associated adverse event after discharge. In fact, we found that there's a 5% increase in the odds of an adverse event per excess day of therapy. It's also been shown that antibiotics prescribed on discharge to long-term care facilities increase a patient's risk of 30-day emergency room visits and C. difficile within 60 days. So this is just directly what we know about antibiotics at discharge, but there's a lot more studies that have looked about antibiotic overuse overall that have shown that really antibiotic overuse increases risk of adverse events, C. difficile, and antimicrobial use or antimicrobial resistance. We've talked a little bit about the types of antibiotic overuse at discharge. Let's talk next about why transitions are such a challenging environment. So based on our conceptual work to date, we've come up with a conceptual model that includes 4 key reasons for why antibiotics are overprescribed at discharge. The first is knowledge and guidance. So if you think about national guidelines or your local guidelines, they often focus on what you should prescribe patients when they're first hospitalized. But we reviewed a lot of the antibiotic stewardship guidelines across the state of Michigan for different hospitals and found that most of them are mum when it comes to what you should do to patients as they leave the hospital. And this actually reflects what happens a lot in our national guidelines. Our national guidelines often don't offer recommendations about transition to oral, step-down therapy, or discharge prescribing. And when there's no guidance, that means that provider knowledge is sometimes limited. There's also the problem of uncertainty as patients leave the hospital. I know one of my big concerns as a hospitalist is that a patient's going to be safe when they leave my care and that they won't be readmitted. This is a hard thing to address, but I think it's important to know that prescribing longer durations or broader spectrum of antibiotics at discharge actually makes your patient, does not reduce the risk of readmission for your patient, and actually increases their risk of adverse events associated with those antibiotics. So we need to really reframe how we think about this uncertainty issue. Then there's also the issue of restarting the clock. And to dissect this for a second, I want to show you some of the things that we found when we were looking at pneumonia prescribing and discharge. So what we found is that if you look at patients' expected antibiotic duration after discharge based on guidelines and the proportion of patients with either community-acquired pneumonia or healthcare-associated pneumonia that were expected to have certain discharge durations, the top discharge duration expected at discharge was actually 0 days. And then it kind of falls off after there with a smaller number of patients who were expected to have 1 day, 2 days, 3 days. Very few were expected to have more than 5 days. But if you look at what providers actually prescribe, I think the first thing you notice is that community-acquired pneumonia and healthcare-associated pneumonia look almost identical. So their discharge prescriptions aren't really being determined based on their disease state. But it is also the most common durations are not 0 days, but 5, 7, and 10. So really providers are restarting the clock or prescribing entire courses of antibiotic therapy as patients leave the hospital. And then finally, the fourth thing that causes antibiotics to be overprescribed at discharge is this idea of diagnosis momentum, which is what we talked about with our case review, where diagnoses are added, but it's really hard to get rid of a diagnosis once it happens. So even though a patient, you really no longer think they have pneumonia, that diagnosis continues and therefore the treatment continues. So now that we've talked about challenges, I want to talk about some of the best practices and potential solutions. But first, let me say what I know doesn't work, and that's only doing inpatient antibiotic stewardship. So we looked at a subset of our patients, about 10,000 or so, And we looked specifically at fluoroquinolone prescribing. And some of you out there may know that two of the strongest recommended interventions related to fluoroquinolone prescribing are pre-prescription approval or prospective audit and feedback. So what this means is it's usually a pharmacist, but can be another provider who either has to be paged before an antibiotic can be prescribed, or at some point hours to days after an antibiotic is prescribed, reviews those prescriptions, and then will call a provider to offer feedback and suggest changes. So this is called either pre-prescription approval or prospective audit and feedback. Very manpower heavy, but very effective, and have been shown before to really reduce antibiotic prescribing. And so a lot of hospitals use this to try to reduce rates of fluoroquinolone use. And when we looked across the state of Michigan, we found that 14 hospitals targeted fluoroquinolones in one of these ways. And then 34 hospitals may have targeted fluoroquinolone prescribing through education or another way, but didn't use one of these two interventions that's really robust to target fluoroquinolone prescribing. So what did we find when we compared these two types of hospitals? First off, we found that 11% fewer patients received a fluoroquinolone in hospitals that targeted fluoroquinolone use using one of these two mechanisms. However, those hospitals had double the number of patients who were newly started on a fluoroquinolone at discharge. So in other words, antibiotic stewardship really worked to reduce inpatient fluoroquinolone use, but paradoxically had an increase in new fluoroquinolone use at discharge. So because stewardship wasn't really paying attention to what was happening at discharge, and perhaps because providers were trying to work around or hadn't really been convinced about the problem with fluoroquinolone prescribing, they were often prescribing these at discharge instead. So based on our work in this area, we've created some best practices related to discharge stewardship. The first, actually talk about it in your guidelines. So like I said, most institutional guidelines that we looked at really didn't give guidance for providers on what they should do when it comes to discharge. So we've actually incorporated this into our guidelines and been very specific about it. For example, our discharge recommendations look like this. So we have a disease state, we have a preferred oral antibiotic with doses given for normal renal function, and then a preferred total duration, which we remind providers should include effective inpatient duration. And we provide this for patients who overall get clinically stable quickly and don't have other comorbidities or complications of their infection. So for example, for pneumonia, patients who have community-acquired pneumonia, we recommend amoxicillin clavulanic acid, 875 milligrams BID for 5 days. For patients with risk factors for resistant bacteria, we do recommend a longer duration of 7 days. For patients with urinary tract infection, we remind providers that treatment should only be given to patients with urinary symptoms. And then we break it down by type of urinary tract infection, whether it's uncomplicated cystitis, more complicated cystitis with things like catheter-associated urinary tract infection, and then uncomplicated pyelonephritis. And we have different recommendations by disease state, as well as different recommendations for duration. So in addition to providing concrete guidelines for providers, also try to incorporate this into the education. This doesn't necessarily mean that you need to give an educational talk to providers about discharge prescribing, but if you're going to go to providers and talk about pneumonia treatment, in addition to talking about empiric therapy, you should talk about when providers should de-escalate and what they should prescribe at discharge. These recommendations should also be integrated into any existing work systems that you have. For example, if you have order sets, this should be included in those order sets. And then one of the interesting things we found is related to documentation. So unfortunately, across the state, only 32% of patients who were discharged with pneumonia had a total antibiotic duration documented in their discharge summary. But interestingly, we found that patients who actually had a total duration documented in their discharge summary were less likely to be treated excessively and therefore less likely to have adverse events after discharge. Thinking here that perhaps the act of documenting actually induces a mindful moment where providers are thinking about prescribing more appropriate duration. The other thing that's really important about duration and documenting it is that I can't tell you the number of times that I've heard from nurses at our skilled nursing facilities that it's really hard to stop antibiotics that have been started in the hospital. And so if it's not communicated well what the plan is, patients often will receive unnecessary and excess therapy after they've gone to a nursing facility just because it's hard to overturn a decision that's made in the hospital. And if that decision is not made clearly, sometimes antibiotics continue unnecessarily. So we talked about best practices. What are some potential strategies? I'll talk briefly about some of the things that have come up in the literature. So a lot of you may be doing pharmacist review during hospitalization. So, reviewing antibiotic prescriptions or doing a timeout or something like that. There have been a couple of studies looking at doing this at discharge, and they've had some mild success. I do want to offer some note of caution that there have been both pros and challenges for this kind of strategy. So these strategies are really great for conditions with specific guidelines. If there are good guidelines for treating patients with community-acquired pneumonia, for example, then the pharmacist can really review that algorithm and offer specific guidance back to the providers. Examples of this are duration of therapy, fluoroquinolone antibiotics. And this is really great because clinical pharmacists often already review discharge medications as part of their med reconciliation process. And so if you can include this in their workflow, it doesn't add as much additional burden. The challenges are that it only works for a subset of patients, those who have these really specific conditions with good guidelines. And it doesn't really address unnecessary therapy at all, which we've shown is a big problem when it comes to discharge prescribing. And then there's the problem with compliance. One of the studies, they were only able to look at about 50% of prescriptions, and often providers didn't call them back after they'd made suggestions, and so unnecessary antibiotics were continued anyway. There's also the issue of manpower and workload. And then I'll also say that access to ID pharmacists is sometimes challenging for our smaller hospitals, and we've seen this in Michigan as well. We surveyed hospitals across the state and found that although almost all hospitals had access to any pharmacist, when we looked at pharmacists specifically with ID training, when you got to smaller hospitals, such as those with less than 50 beds, there really was less access to ID pharmacists. And so for some clinical pharmacists, it may be difficult to do some of these more intense interventions unless you train them well, which is what we're actually working on at the University of Michigan. And I will say that probably because of all of these barriers kind of coming together, when we asked hospitals across the state what they were doing, only 17% did any kind of antibiotic review prior to discharge. That was back in 2016. We haven't looked at that more recently, but I suspect that there still aren't a large number of programs that are doing this. So pharmacist review does work really well if you're able to do it, if you have the manpower, but are there any other strategies? So another one is restricting fluoroquinolones. And so the big place that I've seen this done is in some VA hospitals or veterans hospitals across the state. In fact, our VA hospital here in Ann Arbor does this. In fact, fluoroquinolones have been restricted without approval at discharge for more than 20 years. And I have to say, this is the result of one of our amazing ID pharmacists, Steve Weissman, who has taken this upon himself. Initially, he was carrying the pager 24/7, and now that's been shared among some of our physicians as well. But, it's been his thing for 20 years to really restrict fluoroquinolones, even at discharge. Now, I will say that the reason the VA can do this is really because it's a closed prescribing system. So when patients are discharged, their prescriptions are typically filled at the pharmacy that's within the same hospital. It's on the same EHR, and so it's easily integrated. This has been harder for non-VA hospitals where patients often fill their scripts at external pharmacies, and so additional barriers kind of come into play with trying to get EHRs to communicate with each other to do something like this. But I will say that Steve has been remarkably effective, and right now fluoroquinolone prescribing at our VA hospital is really rare. The pros of this are high compliance. This is a 100% compliance unless Steve says it's okay. The challenges are that it's limited to a specific class of drugs. And like I said, for most hospitals, integrating discharge prescribing and stewardship with the EHR is really difficult. There's also the problem of manpower for approval. If you don't have someone who's dedicated or have someone available 24/7, there's a potential that people can try to prescribe around this. And then there's also the issue of the antibiotic police. It's really hard if someone's telling you to do something if you haven't gotten buy-in from all of your providers. Steve's done a great job with this, so we don't really view him that way. But that is a challenge that many hospitals face that try to do this. And then one interesting way of doing this is actually to automate the process. So there was a study done in 2016, published in Pediatrics, and they actually looked at children with skin and soft tissue infections. And for them, when any antibiotic prescription was electronically written at discharge, the total duration defaulted to a 7-day course and then automatically subtracted out the number of days on antibiotics while hospitalized. So this is specifically targeting that habit of restarting the clock when patients are discharged, and they saw remarkable improvement. The pros with this are absolutely high compliance. I will say they use an order set, and I think that many pediatric programs use order sets more often. I know that this is difficult for some hospitals. I know at our hospital on the adult side, our order sets are rarely used. And if you don't have people use the order sets, then it's really hard to have them to automate the system. The other pro is that there's no downtime, so you don't have to worry about weekends or evenings. And then there's really a limited requirement for continued manpower. You put in an initial heavy push, and then after that, the system's automatic. The challenges are that this is very specific subset of diagnoses with very specific recommendations. There's also the challenge of integrating, again, the discharge prescribing with your EHR. And then it does not address unnecessary antibiotic therapy. And then if guidelines change, you really have to make sure you keep this updated, or else there's a potential actually for patient harm. So summary of challenges, the things that we've kind of found in looking through this is that none of these really address unnecessary antibiotic prescribing. They typically only apply for a very particular subset of patients, and then it's difficult often to identify patients in time to intervene. And then finally, integrating discharge scripts and stewardship with the EHR. So we looked at some of those challenges and came up with a project that we're piloting here at the University of Michigan. And that's the project to reduce overuse of antibiotics at discharge, or road home. And what this really is a pharmacist-facilitated diagnostic and antibiotic timeout prior to discharge. Let me talk a little bit about how this works. So it starts with our pharmacist, who during afternoon rounds with the provider asks, do you have any anticipated discharges today or tomorrow? At this point, the hospitalist says, well, potentially Mr. A and Mrs. B. Pharmacist asks, will either of them go home on antibiotics? And provider says, yeah, I'm thinking Mr. A will. That answer then prompts a timeout. And this timeout is both an antibiotic and a diagnostic timeout. So the first question that the pharmacist asks the provider is a bacterial infection the most likely cause of the patient's symptoms? If not, could we consider stopping antibiotics? And the point here is not that the pharmacist actually makes that diagnosis, but just prompts the provider to rethink the diagnosis. If at this point antibiotics can be stopped, then the timeout is done and they skip to documentation. But if antibiotics need to be continued, they then move on with the checklist. Is the most narrow spectrum antibiotic being used? If the patient is being discharged on a fluoroquinolone, is a safer alternative available? It's also at this point that the pharmacist reminds the prescriber that they should confirm and reconsider a patient allergies. We all know that many patients report penicillin allergies, although few actually test positive for an allergy when skin tested. At that point, they then talk about the antibiotic duration and ask, is the antibiotic prescribed for only the minimum effective duration? For example, 5 days with community-acquired pneumonia. If not, they document reasons for why not. And then finally, the pharmacist actually makes the provider to commit to documenting the dose, indication, and total planned duration in the discharge summary. Studies have shown that having people make a verbal, out loud commitment to do something makes them more likely to do it. So at the end of this checklist, together, the pharmacist and the provider have come up with a planned discharge antibiotic. So later that day, let's say, the pharmacist then gets an automatic page for any patients who are discharged on antibiotics. For example, discharge antibiotic orders have been entered for Mr. A and Mr. C. Now, if you remember, the pharmacist already spoke with the hospitalist about Mr. A, but not about Mr. C. So first, she reviews the charts and sees that the prescriber has documented that Mr. A will be discharged on amoxicillin clavulanic acid plus azithromycin for an additional 2 days to complete a 5-day course for community-acquired pneumonia. So you have dose, duration, start and stop days, and indication here. So a great way to document antibiotic therapy. So the pharmacist approves Mr. A's antibiotic, and it's because it's documented well and matches what they had talked about earlier. But because there has not been an antibiotic timeout yet for Mr. C, the pharmacist contacts the provider to perform a timeout at that time. So this kind of acts as a backstop. We're hoping that most of the patients will be identified before they're actually discharged, but if not, there's a backstop so those patients aren't missed either. Now, the goal right now is that what this really does is uses this checklist to facilitate a conversation that happens between the pharmacist and the hospitalist. But the plan long term is to actually automate this system so that the physician is actually doing this timeout within the discharge summary and the EHR so that we don't need the continued manpower, continued intervention of the pharmacist, although they'll be there to do spot checks and to offer advice when needed. Some of the pros about this process are that it prompts a conversation. It's not limited to a subset of patients, and in fact can occur on any patient being discharged on antibiotics, and it specifically targets unnecessary antibiotic therapy. The challenges that we're keeping track of as we move forward is time. So far, each of these timeouts really only take about 45 to 60 seconds per patient. There's the issue of sustainability, which we're trying to work in with the EHR. The issue of pharmacist manpower. We have really great clinical pharmacists who run with our team daily, so that's been really helpful. We're trying to figure out a way to do this in our short stay unit, which doesn't have as much pharmacist availability, to try to continue this there. So we're thinking about some of those challenges ahead of time. And then, like some of the other interventions, we may still miss weekend discharges. Right now, we're working on a process to try to capture those patients on Friday, but we still may miss some of them. So you've heard a lot today about antibiotic overuse and the problems with antibiotic prescribing and stewardship at discharge. So what can you do today to improve antibiotic use at discharge? First off, if you're a provider, when you go back, start performing your own antibiotic timeout at discharge. Think first about necessity. Does this patient even need to be on antibiotics? Think second about your spectrum, and then think about your duration. Specifically here, we're thinking about when we come back to this patient who tells us that this wasn't from a urinary tract infection, this was from a medication side effect. Even if you may have started the patient on antibiotics, don't send them home on one. And then second, really try to work to improve your antibiotic documentation at discharge. Make sure to include the dose, duration, start and stop date, and the indication for antibiotic use. Not only has this been shown to reduce duration and reduce antibiotic-associated adverse events after discharge, but it also helps with communication with your outpatient providers and with those taking care of your patients at skilled nursing facilities. What if you're a pharmacist? Well, if you can, try to work to implement some of these best practices at your hospital. These include incorporating discharge recommendations into your guidelines, incorporating them into your education, and into your work system. Maybe you're saying that you guys already do antibiotic timeouts at 48 or 72 hours. That's great. You don't have to completely change. Make sure you talk about discharge prescribing when you're doing your timeout. We found, for example, that our ID consult team often talked about antibiotic initiation, but then signed off before discharge. And we've now revamped that system, so part of their workflow is to recommend total duration and discharge antibiotics as well. And then the other thing you can do as pharmacists is try to make a policy about documentation related to this and try to make sure that we're improving the way that we document. And then for everybody, if you can, consider doing additional interventions like pharmacist review, automation, or antibiotic timeout. I'd like to take a quick moment to acknowledge everybody at the Michigan Hospital Medicine Safety Consortium who's really helped make this work possible. That includes all of our physicians, all of our pharmacists, all of our project managers, research coordinators, data analysts, the list goes on and on. This work couldn't be done without them, as well as my mentors and collaborators across the state of Michigan and nationally. Thank you for your time, and I'm happy to take questions. If you have any further questions, you can always follow me on Twitter or email me directly. Thanks.